two major takeaways from this article is that bariatric surgery is safe and an effective way to treat obesity and its associated comorbidities, improve health outcomes, and extend life expectancy. And it should be discussed with appropriate patients suffering from obesity. That would be one main takeaway point. And another takeaway point is that because bariatric surgery is so safe and so effective, it is now recommended in patients with lower BMI than prior guidelines, and as well as sicker, older patients that can be good candidates for these interventions. My name is Gal Maurer. I am an obesity specialist in the Department of Endocrinology at Cleveland Clinic.
My name is Ricardo Corcelis. I'm an MIS in bariatric surgery at the Cleveland Clinic here in main campus, and I am also the bariatric surgery fellowship program director.
My name is Beta Mariam Sharo. I'm a medical student and lead author of the review article. Our article name is Bariatric and Metabolic Surgery in the Adult Population, What a Primary Care Provider Needs to Know, and it will be published in the October issue of Mayo Clinic Proceedings. So the main goal of this article was to provide a tool for primary care providers or providers in general that want to educate patients with obesity on bariatric surgery. Despite being the gold standard of treatment, we know that it's severely underutilized, and one of the reasons for that is a lack of comfort in providers in discussing bariatric surgery or obesity in general with patients.
Because of the success of surgery, criteria of surgical interventions have been expanded to patients with lower BMI and type 2 diabetes.
As Dr. Corcelis mentioned, the guidelines have also been recently expanded in 2022 to include patients over a BMI of 35, regardless of the presence of obesity complications, and a BMI over 30 with obesity complications or failure of non-surgical methods. When you compare bariatric surgery to other methods like medical options for weight loss, there's a much more robust data on safety and efficacy that doesn't exist yet for other options for treating obesity, like medical treatment. And you can see this in the paper where we see that after 12 months, we really don't have the data for kind of the GLP-1 agonists and other medical treatment options for obesity. But for bariatric surgery, we have up to 5 years of data and some observational data looking at even lifelong longevity and benefits there. So like I mentioned, this paper is meant to be a tool for clinical practice for providers seeking to educate patients. One of the challenges to doing so is that patients with obesity usually come with major complications, and it's near impossible to address all of them in a single visit. We recommend that the initial discussion on bariatric surgery be simply to address knowledge gaps and educate the patient on their eligibility. But in order to have formal counseling, it's much better to schedule a visit solely for discussing obesity or refer them to a bariatric surgery center. And that is highlighted in a flow chart that we made in Figure 2. But another challenge that providers may find when discussing bariatric surgery with patients is that the risks of bariatric surgery are often overestimated, and the benefits may not be as well understood. So we've also included some comparisons to other types of common surgical procedures to really help highlight the safety of bariatric surgery and why they may benefit.
We use the U.S. national data of postoperative composite complication rates among patients with type 2 diabetes. And we compared different type of procedures, including CABG, including infrainguinal bypasses. We included knee arthroplasty, laparoscopic cholecystectomy, hysterectomy, appendectomy, and a gastric bypass. No, and we saw that, for example, gastric bypass, just to point it out, had 3% complications, same level as hysterectomy, same level as appendectomy. And when we looked at mortality, which is even more, I think, astonishing, is that gastric bypass has lower mortality rates than an appendectomy or cholecystectomy.
It is very critical for primary care providers to familiarize themselves with qualifying characteristics to refer patients to bariatric and metabolic surgery. What's the criteria? to become familiar with benefits and risks so that they can have an informed discussion with their patient. In that primary care providers feel comfortable referring patients to bariatric surgery centers, even if they're unsure if the patient qualifies for bariatric surgery, for example, due to age or due to certain comorbidities, so that a bariatric surgery provider can make a final determination. I would also like to add that even though we have powerful and very effective pharmacotherapy nowadays for obesity, including the GLP-1s, the GIP receptor agonists, not every patient can tolerate these medications. Not every patient can afford these medications. Not every patient wants to take these medications long term. So not every patient is an ideal candidate for this medication. So knowing that there is an evidence-based strategy to address obesity and obesity-associated comorbidities is a very powerful tool that clinicians can use when discussing obesity management.
I think some future areas of research will definitely be comparing head-to-head bariatric surgery with medical management of obesity, which has some challenges, as Dr. Corcell's pointed out, and also looking at patient selection, because that is the most important thing, is understanding who's a good candidate for bariatric surgery versus medical management, even if their BMI qualifies them for both. And that can be patient preferences too, as Dr. Maurer has mentioned. I think another thing we also mentioned in the article is that there are health disparities that kind of get in the way of some patients gaining access to bariatric surgery. We know that ethnic minorities are less likely to have a discussion about bariatric surgery even when they qualify, and the reasons for that are not fully understood. There's some cultural barriers and understanding barriers too. So future research would definitely be needed to elucidate those differences, those disparities, and help us cater to those patients better.
It's clear to me that the future will be combining therapies, especially for patients with class 2, class 1 obesity. I think combining therapies means surgery plus medicine, AOM first, then surgery. So I think that combining therapies will be a key part of the future. And then the need for clear protocols and guidelines. I don't think we have a white paper on obesity management that could be, I think, that the next step of our research, and probably I'll be challenging Betty here and also Dr. Maurer about thinking about a white paper that can be broadly used all over the world. Also thinking about expanding the indications of surgery, and to the question about potential new research, we also showed how surgery could reverse significantly the severity of liver fibrosis, for example. And this is also one of the potential new research arenas that we will be working here at the Cleveland Clinic. And when we think about what's going to happen in the future, we are all, as I mentioned before, very excited about the new GLP-1, the IP analogs. And the problem is that it is complicated to design randomized controlled trial because of cost, and it's difficult. That's the next step, try to randomize patients either to surgery or to the new medications. That's going to be the next step, and still looking for potential ways to obtain those funding.
New guidelines are coming up from the Obesity Society, Obesity Medicine Association, and even Obesity Canada. The American Diabetes Association is also coming up with some new guidelines. So I think the conversation will keep going in terms of how do we combine these modalities? How do we use them individually? How do we use them together? How do we use them with lifestyle interventions? A lot more to come.
For further details on bariatric surgery and eligibility, we invite you to read our article in the October issue of Mayo Clinic Proceedings.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.